Chronic wounds. I mean, we've done it topically a lot. Both Sebastian and I have used naltrexone. In fact, I was just talking to a pharmacist down in Georgia today, and they were seeing they kind of stalled out on closure of the wound, and when they added naltrexone in it, it closed up almost immediately. We're doing like a 0.5% or less in a lot of the wound formulations, but it depends on what else is going on with the wound. As a single standalone ingredient, I don't usually use it as a single standalone. As Sebastian mentioned earlier, when you see patients, because of that SNP and their TLR4 receptors and the genetic predisposition, you don't know who's going to respond well, who's not going to respond well. We've actually seen a few patients when they're treating, topically, that to get some paradoxical inflammation from it, right? So we try to make sure I think that oral is always the safest route to go, just saying, from a reduce the adverse event perspective, and to get the immune modulation, because a lot of times wound closure is hard, especially in older patients, because their immune system's not as happy, their hormones are not as happy. It's kind of hard to close a wound if you don't have adequate androgens on board. So it's a bigger picture thing for a lot of people.
And I'm going to roll along with this one for any chronic wounds. You orally works extremely well. We've seen patients using things topically, and it really and truly depends upon the patient and what success you're having. So the nice flexibility within the group of compounding pharmacists is, this way doesn't work. Well, we always have an option. We have a cream for that, or we have a capsule for that. Take your pick, but we can adjust to the patient's best outcome at the end of the day.